Good afternoon, everybody. Thank you for coming from rounds again. It's my pleasure to introduce Dr. Ryan Lett. I'm sure most everybody knows him here, but for those who don't, he's a local anesthesiologist here in Regina. He's going to be talking to us about connecting cardiovascular conditions, and as his role as the transfusion committee leader and later for patient blood management, advocating for improved transfusion practice, he's going to be showing and going over some of the principles that are applicable to cardiology in terms of transfusions and iron treatments. In 2018, he joined the National Advisory Committee on Blood and Blood Products as a provincial representative, so I'm sure he's going to have lots of useful information. So thank you for coming, and thank you, Ryan.
So I kind of came about this a roundabout way. Dr. Lavoie asked me to come and talk about IV iron and heart failure specifically, but everything I've done up until now has been approaching everything from an anemia perspective and talking about, okay, transfusion for anemia doesn't lead to better outcomes, but iron does. And then when you start to approach heart failure, you start to realize that we've actually sort of done the same thing in heart failure. So this is why I'm going to talk a little bit about transfusion and then a whole lot more about IV iron. So we're starting to get more and more evidence on transfusion and anemia that it's probably both are bad for the patient. The idea that transfusion improves anemia or outcomes has really not been borne out in any of the literature that has been published in the last 25 years. And then we'll talk about why IV iron seems to bypass some of that and actually seems to make a difference for patients. And then part of what eventually sort of my ultimate dream would be to see is if we can get on top of the iron deficiency piece, you actually tackle the anemia piece at the same time. And ultimately, you get better outcomes for patients. So I've actually given an educational lecture paid for by Pfizer before. That's my one disclosure. So we'll talk. This is from Iron Deficiency and Heart Failure, just published in 2019. Really good article. It's available. You can access it online for free. But we're going to start by talking about blood. We'll talk briefly about erythropoietin-stimulating agents, and then we'll finish with iron. So we've known for a long time that iron deficiency is very prevalent in a lot of diseases, including heart failure. So in heart failure, this slide says up to 50%. If you do bone marrow biopsies on people in heart failure, it's probably up to 73% of them actually have bone marrow evidence of iron deficiency. And what that translates into is if you have patients who have anemia, chronic kidney disease, and heart failure, you have increased risk of death. Surprisingly, anemia is actually the same degree of risk to a patient as chronic kidney disease, which as an anesthesiologist in the pre-admission clinic, we get people through with heart failure and chronic kidney disease all the time saying, please see this patient before they come to the operating room. And for both kidney disease and heart failure, usually they've got good follow-up with cardiology and nephrology. And you kind of say, well, nothing I can do. But anemia is a movable target, and you can actually improve it without transfusion and improve patient outcomes. So the whole idea that blood saves lives, this is largely what everybody has believed since childhood because we've done a really good job of advertising it. But that's just all it is. It's literally all advertising. There's never been a study showing that blood saves lives ever, anywhere. So the whole idea, this is from Nature in 2015, they published a review article on blood. It's actually probably the opposite. The less blood you give, the more likely you are to save lives. And this was an article that focused on Stanford's reduction of blood in high-risk surgery. They reduced their transfusion rate by 25%, increased their throughput of patients, decreased their mortality rate by almost 3% in the same setting, and improved patient outcomes overall. So in case you're wondering what else has changed in the advertising world since the 1940s when we had these campaigns, we see the same thing. And interestingly, if we were to ask you, how many of you believe that we've got good, strong evidence showing that smoking causes lung cancer? Almost everyone would probably say yes, they agree. But there's never been a randomized controlled trial showing that. Likewise with blood transfusion, I don't have a randomized controlled trial to say blood causes this, but when you start to see the same thing over and over and over and over again, eventually you have to ask yourself, there's something here and maybe we should be paying more attention to what that signal actually is. So this is all of the associations of red blood cells, and we don't really do a good job of actually telling patients that these are all the risks that are inherent with them. They've got increased risk of organ dysfunction, length of stay, mortality. They actually have increased risk of thromboembolism that's directly proportional to the number of units that are transfused. Bleeding is more likely to reoccur if they're transfused. They have a higher risk of infection. And then if you're in the setting of cancer surgery, you actually have a higher risk of cancer recurrence if you receive a blood transfusion at the time of your surgery. So this is part of the problem. This is what we all conceptualize red blood cells as, is this nice malleable form of a cell that will actually fit through your capillaries and deliver oxygen to your tissues. The problem is after you've taken the blood out and stored it for a while, it starts to look a lot more like this. You get deformed red blood cells that actually don't make it through your smallest capillary beds. They also don't release the oxygen to the tissues. So even though you think you're delivering oxygen to the ischemic tissue, you might actually be making it worse by plugging up some of those smaller capillary beds. If this is in cardiac surgery, they've looked at this over and over and over again. The top two lines are if you went for cardiac surgery and you weren't transfused, whether you were anemic or not anemic, you had less mortality. If you were transfused and you weren't anemic, it was increased. And if you had anemia and you were transfused, your survival was actually the lowest. They took a look at and subdivided that a little bit further. If you had anemia and you were transfused, you also had the highest troponin, length of stay, lowest kidney function, highest mortality, and longest ventilator requirements. I could show this slide after slide after slide. They've done this in multiple populations, including children. It all sort of looks the same. If you're not anemic and not transfused, you're at your lowest risk. If you're anemic and transfused, or not anemic but transfused, you have about the same risk. But as soon as you combine the two, anemia plus transfusion, your mortality skyrockets. So these are not randomized controlled trials, but some of our Jehovah's Witness studies provide the opportunity to say, well, how are we doing with a Jehovah's Witness population? Now, because these trials aren't randomized, you have to understand that these patients are actually getting a different level of care. Okay, so they're, number one, we aren't checking their daily CBC to see how they're doing, because we know that will increase the rate of anemia. We're replacing iron early. We're giving them erythropoietin early. So there's a lot of things that are actually different between these two groups. It's not necessarily the transfusion per se that's the difference here. But for all comers, you see that they actually have a lower mortality rate by 2% if they refuse a blood transfusion and go through the process of being optimized. We actually have it in cardiac surgery as well. Again, we probably take better care of people who say, I don't want blood, because there's no safety net beneath them. So all of the bloodletting procedures that we do afterwards, including additional blood work draws, we pretty much kibosh. And so you lose less blood, which means your postoperative hemoglobin is higher, and there is a tendency to have a shorter ICU length of stay. If you were to take a look at everything, the one that actually jumps out as being actually almost statistically significant is actually they have a lower rate of myocardial infarction if you don't give blood, which is maybe a little bit surprising. We have almost 15,000 patients worth of randomized controlled trials comparing liberal transfusions versus restrictive transfusions. Of these, only a couple, well, there's a lot of cardiac surgery, but there's this one probably jumps out as the one that's the most applicable to cardiology, because in order to be recruited to this trial, you had to have a hip fracture and have a risk factor for cardiac disease. And again, they used a cutoff of 80 or 100, and there was no difference between the two groups in terms of any outcome that they looked at. The other one that was interesting is this is the largest cardiac surgery that was done, just published in 2017. They used a cutoff of 75 versus 95. And one thing that probably most people aren't aware of is early on with the TRIC trial, there was a suggestion that if you were older, you maybe did a little, or had more comorbidities, maybe you did better if you got more blood. This one is actually completely different. They actually achieved statistical significance, which the TRIC trial did not do in that setting. And the older you did, the worse you actually did with transfusion. So it's interesting, at least in the cardiac surgery population, the older you were if you received a blood transfusion, the worse your outcomes. So we don't have good randomized controlled trials specifically in the setting of MIs, but we do have some interesting animal studies, and this is why I think it's interesting. This is looking at the effects of anemia and transfusion when you basically give a rat an MI by clipping their left main. So if you're anemic, you have reduced survival. You also have increased infarct size and reduced cardiac function in the anemic groups. Now, if you transfuse with fresh blood, and this becomes really important, and I'll go over the subsequent study in a second, up to 100 grams per liter, you actually improve cardiac function and improve survival. But if you over-transfused, you achieved the same degree of infarct size, reduced cardiac function, and again, no difference to survival. So there's a very fine balance of what's the appropriate transfusion level in these patients. So this is actually the same group. They took a look at what degree of fresh blood do you actually need. And at anemia levels of 80 to 90 degrees, they had the same thing. They clipped the left main, and then they either transfused fresh blood, which was blood that was collected within 4 hours, or stored blood, which for rats was after 7 days, and transfused to 100, or no transfusion. And the group with fresh blood reduced their infarct size, but not the stored blood, so anything over 7 days. Now, we actually have some we have observational trials in humans looking at old blood versus fresh blood. The problem is that in humans, the cutoff for fresh blood is anything less than 10 days old, because it's really hard to get blood within hours from a donor to a patient. So again, we don't exactly know. This was a really interesting study. So in the sense that we haven't known what the mechanism of injury is for red blood cells, and this starts to provide some light to it. So how many of you have heard the saying, oh, well, we don't need to give this patient IV iron because there's iron in blood? That's actually a true statement. There's iron in blood. It's in the form of hemoglobin. As that hemoglobin hemolyzes, it releases the iron. The problem is that heme iron is actually reactive in the body, which will activate endothelial disruption and specifically targets the kidney. So when you start transfusing people red blood cells, essentially, you actually see a higher rate of kidney injury and endothelial damage, essentially, with transfused blood. And this is part of the mechanism why. This study was looking at ways to prevent that, and they said you can prevent it if you infuse haptoglobin concurrently, but currently that's not available for widespread use, so I don't see it coming out anytime soon. So what do we have for evidence in patients in the setting of myocardial infarction? Well, these are not randomized controlled trials. These are all observational. And yet what we see is these meta-analyses of 21,000 patients. You see a higher rate of in-hospital long-term mortality, repeat stenting, higher reinfarct rates, stroke rates, and heart failure. The problem, at least in this article in 2018, is that the group that was transfused also has the lowest hemoglobin level. So is it the anemia that's the problem, or is it the transfusion? This was a subgroup analysis looking at patients with ST elevation MI being transfused. And again, there was a significant increase in mortality if you were transfused at the time of ST elevation MI. Again, the problem in this group is that most of those patients had some sort of bleeding issue as well. And so again, is it the bleeding or is it the transfusion? Tough to say. We do have other evidence from cardiopulmonary bypass looking at direct myocardial injury as evidenced by troponin rise. If you're transfused while on cardiopulmonary bypass, you'll have a higher troponin than if you're not transfused. This was probably of the 4 that I've shown, this is probably the best one, and they claimed that they were able to account for both bleeding and anemia. And they found that the number needed to harm from transfusing patients was 8, which is actually a really low number in the number needed to harm realm. It significantly increased mortality, had a higher subsequent risk of myocardial infarction, and it actually was independent of baseline hemoglobin, lowest hemoglobin, and change of hemoglobin in their stay. So this is what we're kind of all waiting for, is this MINT trial. Because it's a randomized controlled trial in the setting of myocardial infarction to maybe give us some better direction as what's actually going on. Based on everything I've showed you, would anybody take a $5 bet that this will show same outcome between liberal and transfusion or better? My guess is it'll probably be the same or worse. Now, as far as recommendations from every organization that's out there, we've had these recommendations since 1988. We probably need to start following them a little bit better. In the sense that we treat it sort of like buying milk. You get so close. You're like, I'm almost there. I'm almost to 70, or I'm almost to 80. Close enough. Let's just give you a unit. The weekend's coming up. Like it's that kind of attitude. We actually need to start being so liberal with how we transfuse and saying, you know what, as long as they're not symptomatic, we're going to wait until they cross this threshold before we even consider transfusion. There's newer research that's come out. If you're young and asymptomatic, the reality is you can probably tolerate hemoglobins to less than 50. And this is the issue right here. So this is basic physiology that probably has come up in a textbook at some point in time, and everybody's kind of shut out of their memory. But physiologically, at some point in time, your hemoglobin will drop to a point that's low enough that it barely meets your basal metabolic requirements. And you can do the math, and actually both mathematically and physiologically, they've tested this, and it works out to be about the same. So if you were to put a scale on here, the point where you drop off the curve is about 20 to 25 grams per liter for hemoglobin. So that's about as low as you can go before you start seeing a delivery of oxygen issue that's a problem. Now, if you wanted to show a really strong benefit for transfusion, this is where you would actually study it, would be in that 0 to 40 grams per liter range, because this is where the delivery of oxygen via red blood cells makes a significant difference. This is where we actually study it, is in the range of 70 to 100. And so it really isn't that much of a surprise that between all these liberal and restrictive transfusion trials that we've done, there really hasn't been any difference in terms of benefit with more blood. This is just the experimental evidence. Again, we can increase hemoglobin by transfusion. We know that, everybody in the room knows that. Some of the trials even say that we can increase the delivery of oxygen, but what we haven't been able to show is that the body uses more oxygen if you provide more hemoglobin. And at the tissue level, using lactate as a marker, we've never been able to show that we've improved tissue function with transfusion. So the summary of transfusion, there's still no clear evidence that transfusion improves outcomes, and there is a significant possibility that harm is commonly caused using transfusion. If the patient has no signs or symptoms of ischemia, a restrictive threshold is warranted. So let's move on to the erythropoietin stimulating agent. I'm only going to have one slide on this because it kind of summarizes the whole thing. This was a study that was done in 2013, or finished in 2013, but it was almost 5 years worth of following patients using darbepoetin to increase their hemoglobin. And as you can see, if you got darbepoetin, they were able to increase the hemoglobin level significantly over placebo. But when you actually looked at what came out as their primary outcomes was reducing death or hospitalizations, there was no difference. So the summary is, you can increase the hemoglobin using erythropoietin, but you won't make a difference in outcomes. Now, it doesn't mean it's useless, because there's times, for example, in the operative realm, where using erythropoietin to avoid transfusion when they go for surgery actually makes really good sense. But for long-term maintenance therapy at higher hemoglobins, it probably is not useful in a heart failure population. So now we're going to get to the good stuff on iron. So iron deficiency in heart failure, really, really common. Like I said earlier, up to 73% of people will have iron deficiency in heart failure. The left graph is the total incidence. Iron deficiency plus anemia starts to increase, especially with the higher New York Heart Association gradings. And same thing with iron deficiency and anemia, you have the lowest survival rate long term. So choosing wisely has been saying this for about 5 years, is don't transfuse if iron would be just as effective. And I would actually say maybe even better than blood. We know if we compare the risks with transfusion compared to the risks of intravenous iron, the risks with IV iron, despite it historically being something that everybody feared because of complications, actually has lower complications than transfusing red blood cells. If you looked at what we currently have available in Regina that we're using for iron, we're using iron sucrose or iron isomaltoside, which just came out. The incidence of adverse events with those two forms of iron, severe incidence, is about one in a million now. So it's actually extremely low. Now, this is the whole reason why IV iron is maybe more beneficial, especially in the heart failure setting compared to other areas, is when you have a condition that leads to some type of activated inflammation, whether that's heart failure, diabetes, cancer, kidney failure, etc., you have this upregulation of hepcidin. Hepcidin is your master regulatory piece of iron metabolism. When your hepcidin goes up, you stop absorbing oral iron. You also stop releasing iron from your macrophage stores to be released for erythropoiesis. So it's sort of a double effect. Now, the right thing would be to develop a hepcidin inhibitor, and maybe we could use oral iron or food to do that. And those are in development, but we're not there yet, and we probably won't be for 10 to 15 years. So if you're looking at lab tests, if you see somebody who has one of these underlying inflammatory conditions, and all you check is ferritin, ferritin is probably going to be high, but it doesn't mean anything when it's high, because inflammation will directly make it high. What you want to know is what's their percent saturation. If their percent saturation is low, you have an iron responsive condition, or likely have an iron responsive condition. If you do have a patient whose ferritin is low, like less than 30, that patient will probably do really well with oral iron early on. So this is again from the same article, the JACC article. This is their recommendation for people with heart failure. If you have heart failure, and the studied groups, or the most studied group, is those with reduced ejection fraction, and their hemoglobin is less than 150 grams per liter, which is higher than I've been recommending for anemia screening, which is 130, then take a look at their iron studies. If their iron studies are low, then consider IV iron treatment. If their iron studies are high, or their hemoglobin is greater than 150, they probably don't need IV iron. And this has actually been embraced by the European Cardiology Group since, I think, 2016 is when they endorsed it. The American Heart Association, they're a little bit less enthusiastic. They say it might be reasonable. So incidence of iron deficiency, as mentioned, and iron deficiency is actually an independent risk factor for poor exercise capacity and mortality. And the mechanism of improvement is independent of hemoglobin restoration. So we'll talk about that a little bit. So IV iron safety, just in case I need to convince you a little bit more, it's actually protective if you have GI illnesses, specifically the ulcerative colitis or inflammatory bowel disease, because it bypasses the whole absorption piece. And also in heart failure and cardiovascular disease, it actually is probably protective. It does have downside side effects, and we'll talk about them a little bit later. Infusion reactions are fairly common. If you get enough IV iron, you will eventually have to deal with an infusion reaction. Usually they're minor. You get a bit of a rash or hypotensive or lightheaded or nausea or vomiting. Those are really common. Those are all included there. Hypotension is really common, particularly with iron sucrose. Interestingly, I learned this. Hypertension is supposedly more common, but they don't tend to call you when patients' blood pressure is a little bit higher than normal. They only call you when it goes low. So I don't see that one, that one isn't reported quite as much. But there's actually no association with infection, thromboembolism, or iron overload. And the infection piece is really important to take a look at, because historically they said, oh, we can't give iron because there might be a risk of infection. Now, if you're actively septic, I would agree with that. But if the patient has been treated with antibiotics, or you're not worried about infection, overall there's no association. Now, this was a study looking at IV iron after cardiac surgery. They reported it as IV iron doesn't increase the infection rate. What they didn't mention is that transfusion did increase the infection rate, and that's been shown in multiple studies across multiple populations. I took a lot of the slides out because I wanted to get to the end of this so we can finish, but if you have a lot more questions about the infection piece, I'll be happy to pull out those other studies. This is another thing that was really interesting, is the thromboembolic piece. This was looking at people with cyanotic congenital heart disease, and they happened to have iron deficiency data on it. It was actually a stronger predictor of stroke than atrial fibrillation in those with congenital heart disease. This was also shown in another study with pulmonary AVMs. Sorry, this translated from a Mac to a PC in my box, has slightly moved over, but the iron deficiency showed up again in that group. And this one was really interesting because they took those patients who were iron deficient and had had a stroke, and they did some platelet mapping studies, and they found that your serotonin receptor increased platelet aggregation if you were iron deficient, and as you corrected the iron deficiency, the platelet aggregation went down, which is really important. So now you have a mechanism of how this actually works. You also have a mechanism of how iron will actually decrease platelet counts overall. So it'll both decrease platelet counts and decrease platelet aggregation as you restore iron stores. So the first time I came across this was in the American Journal of Hematology. There was a nice review. They had 838 patients in randomized controlled trials using IV iron. And what they showed is that you were actually able to improve ejection fraction in the setting of heart failure. So EF's typically less than 40%. People felt better. Their quality of life improved from being short of breath all the time to being short of breath only with exertion. They were able to walk farther. They had less fatigue, and they had less or improved quality of life, specifically less depression, less pain, better mobility, and better able to take care of themselves. So I then started to look, well, how does that actually do that? This was looking at just echo findings using tissue Doppler strain, and both S prime, which is a marker of systolic contractility, and E prime, which is your diastolic function, between 8 and 12 weeks is where you saw maximum benefit to the patients. And regardless of whether the patient was on optimum medical therapy or not, all of the patients improved in terms of functional class. This one started to go into a little bit more. This is maybe hitting really hard after lunch. This is the one that would put me to sleep in like physiology class. But how it actually works is it improves how your ATP is buffered. So iron shows up in every cell in your body, and it's important at your mitochondrial level for basically generating ATP. If you have good ATP recovery time, you have increased this phosphocreatine, which they're able to measure, which showed up in the, so as you shortened that, you had improved recovery of ATP. You also had improved signs of function, and when they did these weight-bearing exercises. And to put it in perspective, it was the same as if you were a highly trained individual and you did 2 weeks of very intense exercise. This is sort of the mechanism of why ATP is important in heart failure, is when your heart contracts, your ATP and myosin form a complex. The actin then displaces the used ADP molecule to get a contraction with your actin-myosin complex. And as ATP is regenerated, it displaces the actin, allowing it to both contract and relax. So ATP is important for both basically systole and diastole if you want to see a change in function. This might make it a little bit more clear in terms of pictures. So you've got your mitochondria generating, turning around your Krebs cycle, generating ATP. It's a much more efficient cycle if you're completely iron replete. You have better beta oxidation of lipids. You also have better glycolysis to generate ATP. And one of the things that I think maybe when we compare oral iron versus IV iron is because IV iron gives you a surplus of iron really quickly, I think some of that iron is getting into the cells better. Because if you look at the studies on oral iron in heart failure, you can improve, again, you can improve the hemoglobin, but you're not necessarily seeing an improvement in function. And I think what's happening is because the absorption of oral iron is really slow, the body is prioritizing that for hemoglobin production, and you don't get the same amount dedicated to cellular restoration of iron. Again, you can see it at every single level going up from tissue right down to the mitochondrial level. Improving iron improves how that muscle is going to contract. That's true for both skeletal and cardiac muscle. So this is the most current review of all the trials that are out there. We've got up to 1,400 patients in randomized controlled trials now using IV iron. All-cause mortality, maybe some studies have shown a benefit, but overall it's probably no different as far as mortality when you've got a high-risk group of people with heart failure. But it does reduce hospitalizations in heart failure. The number needed to treat was 10 at between 6 and 12 months after therapy. It improves New York Heart Association classifications. So 50% more people will actually improve heart classifications if you treat them with IV iron. Your markers of heart failure will actually get better. Your 6-minute walk tests improve. Your ejection fraction gets better. This one we'll see long-term what this one shows, because I'm a little bit less convinced this is always going to be the case. But in the studies so far, this has definitely been showing iron as improving ejection fractions. And then multiple studies, particularly in Europe, which is why the European Cardiology Association has endorsed it so well. They've looked at what do you gain patient-wise if you start funding this. They have these qualities, and I'm not a very good statistician, but it's your quality of life years. If you have basically, if it's less than 22,000 euros per year, it's considered cost effective. So for iron, or it's 4,000 euros per year for quality of life year gained. In France, they said it was probably cost neutral, so not a lot gained overall, but it decreased utilization of the public health system. And the most optimistic one was in Spain, where they estimated that it would save between 20 and 97 million euros per year. So we actually have a lot of things in the pipeline coming up. So there are over 6,000 patients in the next 3 to 5 years that should be randomized to IV iron, specifically in a heart failure. These are almost all for reduced ejection fraction, but based on how what the mechanism of action is, it's likely that this will hold true for people who have preserved ejection fraction and are iron deficient as well. So as I was looking into all of this, I wanted to see, like, does this affect other muscles in the body as well? And it turns out pulmonary hypertension is something that probably, if you have these patients with pulmonary hypertension and they're on optimal medical therapy already, you should probably look at what their iron deficiency, or if they have iron deficiency, because what happens with pulmonary reactivity is when you have a what this first graph is showing is your first exposure is the bottom gray line. You were basically given an acute exposure to hypoxia, which didn't demonstrate any, well, there's a little bit of change in pulmonary pressures, but not significant. You then underwent an 8-hour sustained hypoxia piece, and then followed by another acute hypoxia challenge to induce your hypoxia-inducible factors, which significantly increased your pulmonary artery systolic pressures. However, if you gave them iron instead of saline between those hypoxic episodes, iron seemed to suppress the rise of hypoxia-inducible factors, so you didn't see that big increase in pressures. Likewise, they took another group that was iron replete, and they gave them desferoxamine, which is a chelating agent, so it binds to iron and takes it out, and then gave them the same hypoxic challenge. And what they were able to show is that by taking iron out, you started to see your pulmonary pressures creep up again. There's been several studies in pulmonary hypertension stuff, both in animal and human models, and both of them have basically shown the same thing, is that if you have somebody who's iron deficient and you restore their iron levels, you actually improve pulmonary artery pressures. You actually, similar to heart failure, improve exercise capacity and quality of life if you have people with pulmonary hypertension and restore iron levels. And so lastly, I'm just going to talk a little bit about where my interaction with cardiology comes in, is sort of as the last person to see somebody before they go in for cardiopulmonary bypass surgery. If you see these people before surgery and you note that they're anemic, you can reduce their transfusion rate in cardiopulmonary bypass surgery, which probably portends benefit long-term to these patients. This was using just iron alone. This one was actually a little bit more interesting. They used iron and EPO within 24 hours of surgery versus placebo, and they kind of carpet bombed them. They gave them the maximum dose of IV iron, a big dose of erythropoietin, a big dose of B12 and folate, and what they're able to show is they were able to reduce transfusions in the first weekend at 90 days. The caveat is that it cost more than just giving a unit of blood, but on an acquisition basis. It didn't take into account all of the potential sequelae of red blood cell transfusions and potentially higher complications related to red blood cell transfusions. So this is where we are right now, is somebody comes in Regina, they have their acute event, they get optimal interventional medical management. Some of them will go on for a cardiac surgery referral. Our cardiac surgeons are actually getting pretty good about thinking about iron too, so that sometimes it's actually happening earlier. We're reviewing them usually the day before, because that's all the notification we get in anesthesia for when the patient's coming to the OR. And then they have their post-operative recovery. And so far we've been using IV iron in this group here. In an ideal world though, the earlier you get the iron into a patient, the more likely you'll get a hematopoietic response. And if you look at the study or the Doppler study, you didn't see a benefit on diastolic and systolic changes until 8 to 12 weeks. And so I think the earlier you get those iron stores replenished, the more likely you'll see a benefit. One of the problems we have in anesthesia is when you wean somebody from cardiopulmonary bypass, if they have really bad diastolic function, it's really hard to get them off bypass, and so they stay in ICU longer. So if we can actually make a difference in that realm, that would be important. And so this is where we actually need help. So if you see a patient who's coming in, they've had their acute event, you think they might be headed for the cardiac surgery route. If you think iron early, what I've seen happen is they come in with their acute event. There's usually 3 to 5 days before they actually show up in the cardiac OR, which might be enough time to show a little bit of a better benefit. And in an ideal world, we might actually have this done way before the patient even shows up, and maybe it'll actually change things on our acute event rates and hospitalizations, maybe. So here's the summary on IV iron. Is IV iron reduces both platelet count and improves aggregation qualities. It improves skeletal muscle and mitochondrial function. It seems to improve both systolic contractility and diastolic relaxation. It reduces hypoxia-inducible factors and pulmonary pressure in the setting of pulmonary hypertension, improves quality of life, improves hemoglobin, reduces transfusion, and reduces hospitalizations and heart failure. Now, I'm going to kibosh one of those Eastern medicine sayings. The best time for iron replacement was 8 weeks ago, and the second best time is now. So I'll take questions now. I have a little bit more if people want to know how you give iron or risks of iron, but I think this is a good place to stop and just ask if anybody has any questions. So I'll take from the remote sites first and then from here.
Well, thanks, Ryan. It's hi, I'm Dagani from Pasco. How are you? You look good out there in the camera. You're supposed to say you look good too, but you didn't say anything. You know, we in our world in cardiology, we always say bleeding is bad. We have lots of outcome where we show that patients who've had PCI or cardiac event, those who have bled tend to have worse mortality. So, you know, maybe it's not the bleeding, maybe it's the fact that they've been getting transfusions during those hospitalizations. But, you know, one of the things that we cite that I didn't hear you say, I just missed the first couple of minutes, is we often have to stop or interrupt their antiplatelet regimen. We often cite that as an example of, you know, increased thrombotic milieu where everything is stickier because they've had transient disruption in their antiplatelets. Where do you see that? You know, do you see that as a counter argument to, you know, iron being the key, or you know, the blood transfusions being the problem?
So I think, so you're absolutely right in that all of these observational trials, bleeding versus transfusion versus anemia, despite what the one study said and how they were able to statistically separate the few, I think it's actually really hard to do that in the real world. But as to the antiplatelet piece, if you can restore somebody's function or hemoglobin volume without transfusion, I think you actually potentially stand the chance to be able to continue on those platelet agents longer. JAMA just this year published an article on thrombotic risk and blood exposure, and it was a linear relationship. For every 1 unit of red blood cell exposure, you had a linear increase in thrombotic risk. So it's really hard to separate everything out perfectly. And I don't know if that completely answers your question, but I think if you have somebody who's iron deficient and you restore iron stores, a lot of the times they actually feel better even though you haven't changed their hemoglobin number. So even though they may still be anemic, if they feel better, you probably don't need to progress on to transfusion.
Yeah, I guess the difference in our world is, you know, often we're the ones inducing the bleeding, either from mechanically or, you know, the needle has punctured the wrong place, or they have a GI bleed in front of us. I think that's potentially a different scenario because you have a potentially reversible cause of the bleeding and you're more inclined to top up the tank, so to speak. The last thing I'll say is thanks for putting the plug about the MINT trial. As you know, we are a site for MINT. We have 9 patients enrolled. It's an international study. And I think that, you know, you highlight some of the questions. I can tell you we've had some resistance from some of the caregivers about letting some of these hemoglobins go in the liberal arm to the 70s without having to transfuse them. But it highlights a lot of the, you know, misconceptions that you're pointing out.
Thanks, Dr. Lett. I was wondering what your thoughts were in the critical care population, whether you feel that this is maybe more nuanced, or on the other hand, if you think it's even more pertinent because presumably that population might be at even higher risk for all the adverse events that you've described with transfusion, but yet on the other hand, because of their, you know, critical status, people are often very hesitant to permit the hemoglobin to drop sometimes with concerns about perfusion and so on.
So never hear that. So the question was the use of transfusion in the critical care environment. I think actually critical care environment is one of the areas we have some of the best evidence for in terms of restrictive versus liberal transfusions, because almost all of the studies have used a critical care population in terms of, I think the restrictive group does better, or at least as well as the liberal transfusion groups. There have been 3 studies and 1 ongoing using IV iron early in those groups. And the first few were actually all just safety related. They were using them to see, can you give iron and does it increase the infection rate? And so they were giving like drops in the bucket. So usually when you're replacing iron in somebody who's anemic, you typically need 1,500 to 2,000 milligrams. And so the first few studies were using 100 to 500 milligrams to see if it caused a problem with infection, essentially, is what they're looking for. And they didn't find any change in infection, but they also didn't find any change in transfusion rates with those smaller doses. So the last one that was published was a couple of years ago, and they basically said, we've probably reached the limit. We're pretty confident this is safe. It's probably time to buckle down and give them a full loading dose and see if we move the needle on the transfusion piece. So that's kind of where we're at right now in that critical care population.
Ryan, that was an excellent talk. Thank you so much. It's two questions, perhaps, maybe one's a comment. I still have, I'm not trying to be Thanos here, like Iron Man, whatever, but, when you have those supply-demand mismatches and there's a type 2 MI, it's just reflexive that they've had a troponin elevation, myocardial injury, because they're not perfusing. So leading into that, in terms of how quickly could that be a replacement therapy? And then the second question is, it's very intriguing with the heart function improvement. Is there any future studies, or perhaps you mentioned it or alluded to it, in terms of, because now we have diabetic meds that are preventing heart failure. Is this something that could be now a primary prevention therapy? So your heart function gets better, you don't need ICD, et cetera, like just heart failure treatments.
Yeah, I'll start with the second one first, just because it's fresh. I don't know about primary therapy. I don't think anybody's actually looked at that. The one echo study was really small, 40 patients, and yes, you got an improvement regardless of whether you're on medical therapy or not. I kind of look at it. I mean, when you have a complex problem, I don't think like the BB gun approach works very well. I much prefer the shotgun approach, where you target multiple receptors, and I think that's probably the best way to achieve a good functional outcome for patients. I think the iron piece is something. If it's that common and that prevalent, up to 70% of patients, then it's worthwhile absolutely looking for and correcting. I've been very surprised in younger patients without major medical conditions, or maybe with one or two, how quickly they feel better. Like literally, you infuse them with iron, and like 2 days later, they're bouncing. They're like, I've never had this much energy. Like it's profound how they feel. And actually, one of the things in some of the questionnaire studies is, I think they get this big improvement, and that becomes their new normal. And then when you do a 6-month follow-up or 12-month follow-up, their questionnaires kind of taper off. But maybe it's because that's become their new normal. So again, I think using everything you have at your armamentarium is probably the right way in heart failure. The other comment, again, I don't know what the right answer is in the acute setting of MI. I've certainly been trained just like everybody else. If you have a low hemoglobin and you've got ischemia, then give blood. What I'm not sure about is when I look at all these studies on how red blood cells deteriorate, how they tend to function, how they tend to aggregate, how they actually get stuck in some of the smaller capillary beds and may actually block off some of those areas. The answer is I honestly don't know. I think it really has to be a case-by-case basis. If you have a culprit lesion that you're able to stent, then I would say if that improves things, you probably don't need to progress. If you don't have if you've got sort of that small vessel disease and they're unable to vasodilate because everything is so calcified, then that might be a different scenario. Okay, any more questions from?
Hi, it's Ben from the.
Sorry, go ahead.
It's Ben from the CTD clinic. I noticed on that treatment algorithm that you had that it had for if the hemoglobin's less than 150 and they had low iron parameters that you could consider IV iron. We routinely don't order intravenous iron for anyone who's over 130. So I was kind of just wondering what your thoughts were on kind of patients in that area who are their iron parameters are low, but then they've got a relatively normal-ish hemoglobin.
Yeah, so I didn't make this up. That's why I had to take cut and paste this. This is not my recommendation. I've usually been using 130 as the anemia cutoff in the preoperative realm. But I think what the paper is trying to say is that when you have iron deficiency, irrespective of other comorbid illness, you do not function nearly as well. as if you replace those iron stores. I think from a system point of view, it's worthwhile taking a look at the ferritin first. If you have those low ferritins, I think we should always be trying oral iron first, because our outpatient infusion center is swamped a lot of the times as it is with accommodating patients. But I think if this was, my grandmother who had iron deficiency but no other problems, I would probably be pushing for her to go get that checked and actually treated, because I think the evidence is fairly compelling that you actually feel better and function better with your iron stores replete, regardless of what your hemoglobin level is. And it has to do with like subcellular function, which we don't measure well, right? So it's a mitochondrial issue, and I'm not aware of any really good way of saying, gee, my mitochondria are feeling great today. So it's sort of, okay, thank you.
All right, if no other questions on the peripheral sites or locally, thank you so much, Dr. Lett. So I have to call you Tony Stark from now on. But thank you for coming, everybody.